Good morning. My name is Bruce Keogh. I'm the Medical Director of the National Health Service in England, and it's a great pleasure to be able to join you today. And I wish you a very successful conference in what I consider to be a remarkably important area of medical practice. Interestingly, I haven't always thought that, and I've been reflecting on what's made me feel that this is one of the more important areas that we have to tackle in the National Health Service in England. If I rewind by about 40 years, I was sitting at medical school as a medical student, imbibing information on all sorts of things, including Virchow's triad and the risk of blood clots for people admitted to hospital. And yet, when I then became a junior doctor, and it seemed to me that there were relatively simple ways of preventing this, I found a vast array of opinions among my bosses, whether they be orthopedic surgeons, general surgeons, or others. And the most remarkable feature was that nobody agreed. And in my head, that led me to a place, well, that means the evidence isn't that strong, and people are entitled to make their own views felt on this issue and to proceed as they wish. Then I went on to become a cardiac surgeon, and whilst I was aware of the issues of venous thromboembolism, I felt that it was someone else's problem because all of my patients were fully heparinized and most of them had TED stockings. So I was surprised at one point to be presented with evidence that even those patients would come back to hospitals, not necessarily the ones that they were operated in, with pulmonary emboli or DVTs. But the real turning point for me came not long after I was appointed as the first medical director of the National Health Service. At that time I was grappling with some of the very difficult issues of clinical priority in a complex healthcare system, and I was asked to go to an all-party parliamentary group on thrombosis. I agreed to go, albeit reluctantly. And as I sat through the meeting, I listened to a number of presentations, all of which were consistent in their message. First was, we had a whole set of guidelines which determined how we should deal with the problem of venous thromboembolism in the health service. Secondly, a set of presentations which outlined the magnitude of the problem. And this really was one of the striking features. There seemed to be a clear consensus of opinion from a number of research workers from different institutions that about 38,000 people a year died of venous thromboembolism in our hospitals. And most importantly, that about 25,000 of those were avoidable. Now, when it came to question time, I was on the panel, and pretty quickly the president of the Royal College of Surgeons stood up and said, I did my thesis in this 30 years ago, and he said, nothing's really changed. Isn't it time that you as the medical director mandated venous thromboembolism prophylaxis throughout the NHS? And almost immediately, the president of the Royal College of Physicians stood up and issued the same challenge. I gave a pretty wishy-washy answer that it wasn't the job of agents of government to tell clinicians what to do or interfere in the autonomy of clinical decision-making. But I was left with a sense of unease. And as I walked back to my office from the Houses of Parliament, I found myself thinking, what a sad irony that we had a health service where the leaders of the medical profession had to ask the government to tell them to do what they knew they needed to do. And as I reflected on it further, I realized that that wasn't really what they were asking. What they were asking was, please make the health service more receptive to enable us to do what we know needs to be done clinically. So, along with the regional medical directors and the presidents of the Royal Colleges, we decided that the number one clinical priority for the NHS should be tackling venous thromboembolism. It seemed sensible. It seemed we had a problem of great magnitude which affected a lot of people and had long-term sequelae for those people who survived. That we had a number of ducks in a row. We had a set of guidelines, we had a national risk assessment tool which was evidence-based, but what we didn't have was we didn't have a clear implementation plan. So we started to think of that plan, and we started to divvy up the work. It seemed clear that one of the things that the Royal Colleges and the specialist associations could bring to the party is that they could communicate with their members. They could mount a very convincing and compelling case based on science, morality and pragmatism that dealing with venous thromboembolism was the right thing to do. And meantime, I could work with colleagues in the Department of Health to put the right financial levers into the system to help organizations recognize that this was not only a clinical priority, but was something that could be solved. So we put this plan into action, which involved the Royal Colleges and financial levers through the NHS. And I'm glad to report that as of July 2010, when the programme went live, considerably less than 50% of the 14 million patients being admitted to our hospitals every year were risk assessed for their risk of venous thromboembolism. By July 2011, that had risen to 85% and was climbing. And by December 2011, it exceeded 90%. We now have a pretty hard evidence that not only are people risk assessed, but they also receive the appropriate prophylaxis as determined by the algorithm which underpins the risk assessment tool. And furthermore, we're starting now to see early evidence from national data that indicates that the whole strategy may have had a very significant effect both on mortality and readmissions to hospital. I don't want to prejudge that data, but the early data that I've seen is indeed very encouraging. So, on that optimistic note, I'd like to wish you all a very successful conference. Over the years, I've worked on a number of issues with various Australian colleagues, and I've been aware of the good work that you've been doing on venous thromboembolism. I hope that this conference will provide a useful forum for the exchange of ideas between our countries, and I hope that we'll continue to exchange ideas long after the conference is over. So once again, I hope your conference goes very well. Thank you.